A hearty good morning to all. Myself, Dr. Ketki Joshi, on behalf of SOGS team 2324, welcome you all for the most awaited, prestigious, late Dr. V.N. Shirodkar oration. Dr. V.N. Shirodkar, a warm and humane person who had medicine in his veins. He was a clinician who brought a refreshingly fresh insight into any problem. The magnanimous work done by this stalwart is original, path-breaking, and recognized by the whole world. Every year, this oration is presented to a distinguished individual for his outstanding contribution in the field of obstetrics and gynecology. This year, too, we have with us Dr. Kuldeep Singh, sir, a master in the field of imaging. I welcome you, sir, on behalf of Solapur Obstetric and Gynaec Society. I now request President Dr. Virkar sir to escort Dr. Kuldeep Singh sir to the stage. I also request Dr. Neeta Ghate madam, Dr. Meena and Dr. Khare to occupy their seats on dais. Ma Saraswati is the goddess of education, knowledge, and auspiciousness. Let us begin our program with a spiritual invocation, Saraswati Vandana, seeking blessings of goddess of knowledge. I request Dr. Supriya Jadhav to present the Saraswati Vandana.
Thank you, Dr. Ketki. या कुन्देन्तु तुषारहारधवला या शुभ्रवस्त्रावृता या वीणावरदण्डमण्डितकरा या श्वेतपद्मासना या ब्रह्माच्युतशङ्कर प्रभृतिभिर्देवैः सदा वन्दिता सा मां पातु सरस्वती भगवती निःशेषजाड्यापहा शुक्लां ब्रह्मविचारसारपरमा आद्यां जगद्व्यापिनीं वीणापुस्तकधारिणीम् अभयदां जाड्यान्धकारापहा हस्ते स्फाटिकमालिकं विदधतीं पद्मासने संस्थितां वन्दे तां परमेश्वरीं भगवतीं बुद्धिप्रदां शारदाम्. Thank you.
Thank you, Dr. Supriya. I now request Dr. Virkar sir to present the preamble.
Hello.
Good morning, everyone. Respected esteemed guest speaker, seniors, teachers, and my dear friends, I welcome all of you for today's most awaited program, late Dr. Shirodkar, Dr. Shirodkar Oration in the honor of great visionary, legendary figure in the field of OBGY, Dr. V.N. Shirodkar. Dr. Shirodkar, an inimitable teacher who is still loved and respected by students across the nation. He had a very curious and imaginative mind, which ultimately gave the birth to the famous surgical procedure of Shirodkar cerclage, an innovative method to treat the recurrent abortions due to the incompetent os. He traveled widely all over the world and demonstrated his surgical skills and techniques with colorful, interactive slides and films. He authorized many chapters about his views in the various books. He strongly believed that the indications for abortions in our country should be liberalized. He has deservedly awarded Padma Bhushan and Padma Shri Award by the President of India for his valuable work. As a society, since 1989, have also started an oration in remembrance and honor of such a great individual. This year we carry on this tradition, and today we have Dr. Kuldeep Singh as extraordinary academician and a great orator, gracing us with his presence and speak on the topics of vascular indices and impedance through the trimesters for prognosis, diagnosis, and management in FGR. Thank you.
Thank you, sir. Light is considered a symbol of auspiciousness, prosperity, and abundance. We lit the lamp to bow down to knowledge as the greatest form of wealth. So I request all the dignitaries on the dais to come forward for lamp lighting. With great reverence and utmost privilege, I request our guest to pay floral tribute, a gesture of remembrance and gratitude to late Dr. V.N. Shirodkar, sir. Thank you all. I now call upon Dr. Neeta Ghate Madam to present life sketch of late Dr. V.N. Shirodkar.
व्यासपीठावरील मान्यवर, व्यासपीठासमोरील माझे गुरुजन आणि माझ्या मित्रमैत्रिणींनो, मी आज शिरोडकर व्याख्यानमाला सन 2024 मध्ये शिरोडकरांचा जीवनपट उलगडण्याचा छोटासा प्रयत्न करत आहे. Dr.V.N. शिरोडकरांचं पूर्ण नाव होतं विठ्ठल नागेश शिरोडकर. एक संस्कृत सुभाषित आहे, स्वगृहे पूज्यते जनः, स्वग्रामे पूज्यते प्रभुः, स्वदेशे पूज्यते राजा, विद्वान सर्वत्र पूज्यते. अर्थात सामान्य माणसाला त्याच्या घरात मान मिळतो, नेत्याला किंवा पुढाऱ्याला त्याच्या गावात मान मिळतो, राजाला त्याच्या राज्यात मान मिळतो, पण विद्वान लोकांना सगळीकडे राज्यात परराज्यात मान मिळतो. अशी ही अत्यंत विद्वान व्यक्ती म्हणजे डॉक्टर विठ्ठल नागेश शिरोडकर. डॉक्टर शिरोडकर यांचा जन्म अतिशय निसर्गरम्य परिसरात गोवामध्ये शिरोडा या गावी झाला. त्यांचं शालेय शिक्षण हुबळी येथे झालं. त्यांचं वैद्यकीय शिक्षण ग्रँड मेडिकल कॉलेज मुंबई येथे MBBS 1923 साली आणि MD 1927 साली मुंबई युनिव्हर्सिटीतून झालं. त्यांनी FRCS इंग्लंडमध्ये 1931 साली पूर्ण केलं. ते मानद सेवा प्राध्यापक म्हणून स्त्रीरोग व प्रसूतीशास्त्र या विषयात कार्यरत होते. जे ग्रुप ऑफ हॉस्पिटल येथे 1935 पासून त्यांनी काम केलं. डॉक्टर शिरोडकर यांनी वैद्यकशास्त्रात वेगवेगळे प्रयोग केले आणि यशस्वीपणे पेशंट बरे केले. त्यातील एक प्रयोग म्हणजे सर्व्हायकल एन्सर्कलाज. त्या काळात गरोदर स्त्रीच्या पिशवीला हात लावण्याचं धाडस कोणी करत नसे. स्त्रियांची प्रसूतीपूर्व गर्भपात व्हायचे आणि त्यांना मूल गमवावं लागायचं. अशा काळात त्यांनी इंटरनल ऑस येथे स्टिच घालून, त्याला आपण शिरोडकर स्टिच म्हणतो, ही शस्त्रक्रिया यशस्वीरित्या करून मातेला बाळ मिळवून दिलं. या स्लाईडमध्ये आपण पाहत आहात की गर्भाशयाच्या मुखाला स्टिच घातलेला आहे आणि ती प्रोसिजर आहे. डॉक्टर शिरोडकर यांनी वैद्यकशास्त्रात केलेल्या प्रयोगापैकी एक म्हणजे त्यांनी त्यावेळेस टेप किंवा आर्टिफिशियल मटेरियल न वापरता मांडीतील फेशिया हा नॅचरल टेप म्हणून वापरला. पाहूया त्याबद्दलचा एक व्हिडिओ. हा व्हिडिओ मी चिन्मयी राथा यांच्या ह्याच्यातून घेतलेला आहे, व्याख्यानातून. आवाज पाहिजे, साऊंड. हां. तर चालू करा व्हिडिओ, फक्त व्हिडिओ पाहिला जाईल. हा ओल्ड व्हिडिओ आहे, मी परत एकदा दाखवत आहे कारण त्या काळी त्यांनी कसा तो फेशिया घेतला आणि
Association of India as a founding father of that, and had written, was a part of the Shantilal Shah committee. And this we all heard now how he was known nationally and internationally and had some very, very famous patients, starting from Sophia Loren outside India to our very own Indira Gandhi. So he was also a painter, and this is a painting of the Haji Ali that he has made himself, and this is available in one of the papers that Dr. Purandare has written about Indian contribution to obs and gynae, and he has shown this picture there. Dr. Shirodkar also received both the Padma Bhushan and Padma Vibhushan, and this is a little video where we will look at the Shirodkar procedure, all of us, which we talk about. So these are the instruments there, and this is all part of that Diamonds Are Forever series, so you can go back and see there. So what he actually taught us was, instead of using, now we have Marceline tape, we have everything, but at that time we didn't have all this material. So his exact technique involved taking a piece of the fascia lata by making an incision on the skin of the lady. Are you able to hear?
Above and below is carried out. The strip of fascia is then removed. It is approximately 10 to 15 centimeters in length, depending on the size of the cervix. The strip is placed in normal saline until needed. A posterior fornix incision is made, and mobilization of the tissue started. The anterior fornix incision, dissection, and mobilization of bladder and paracervical tissue at the level of the internal os is accomplished. A slip knot is used to lead the fascia through the paracervical area at the level of the internal os beneath the cervical fascia. The left fascial director is introduced and further blunt dissection carried out. The fascia is attached to this left director and the strip pulled out at the anterior fornix incision. A similar procedure is employed on the right side of the cervix with the right cervical director. The fascia is now encircling the cervix at the level of the internal os.
पुढचं slide. नाही नाही पुढचं. त्यांनी पहिलं सर्वायकल स्टिच ज्यांना घातलं त्यांचं ते पेशंट पण त्या गायनेकॉलॉजिस्ट मॅडम होत्या डॉक्टर सोबती, आणि त्यांनी जे बेबी डिलिव्हर झालं ते म्हणजे डॉक्टर मानू सोबती. ते साल होतं 1953. त्यांनी या शस्त्रक्रियेची विदेशात पॅरिस येथे डॉक्टरांच्या परिषदेत माहिती दिली. या शस्त्रक्रियेसाठी लागणारी हत्यारंही त्यांनी स्वतः तयार केलेली होती. त्यांची अजून एक शस्त्रक्रिया म्हणजे शिरोडकर स्लिंग ऑपरेशन, जे की योनिमार्गातून बाहेर आलेलं गर्भाशय लूपनी वर बांधणं. ही शस्त्रक्रिया जवळजवळ सगळ्या मेडिकल कॉलेजेसमध्ये केली जाते, शिकवली जाते, आणि अजूनही बरेच जण ही शस्त्रक्रिया करतात. दुसरी प्रोलॅप्ससाठीची शस्त्रक्रिया म्हणजे शिरोडकर एक्सटेंडेड मँचेस्टर ऑपरेशन. हे यंग प्रोलॅप्स ज्यांचं युट्रो सर्वायकल लेंथ जास्त आहे अशा स्त्रियांचं मॅकॅन्डॉट्स लिगामेंट कट करून अँटिरियरली बांधलं जातं. ही शस्त्रक्रिया पण सगळीकडे केली जाते. सोलापुरात पण सगळ्या मेडिकल कॉलेजेसमध्ये केली जाते. त्यांची आणखी काही ऑपरेशन्स म्हणजे क्रिएशन ऑफ न्यू व्हजायना, जसं की नवा योनिमार्ग तयार करणे कोलॉन वापरून, आणि ट्युबोप्लास्टी ऑपरेशन, ज्या गर्भनलिका बंद आहेत त्याचं इम्प्लांट युट्रसवर करणं. ऑपरेशन थिएटर हे खऱ्या अर्थाने ऑपरेशन थिएटर असं असायचं शिरोडकरांच्या काळात. थिएटर म्हणजे आपण एखादी चित्रफीत आणि एखादी गोष्ट पाहतो असं. तर शिरोडकर जेव्हा ऑपरेशन करायचे तेव्हा त्यांचं ऑपरेशन बघण्यासाठी अनेक सर्जन, नावाजलेले डॉक्टर येऊन बघत आणि ते खऱ्या अर्थाने ऑपरेशन थिएटर असं व्हायचं. शिरोडकर यांनी डॉक्टर असण्याबरोबरच समाजासाठी बऱ्याच गोष्टी केल्या. ते फॅमिली प्लॅनिंग कमिटीचे सदस्य होते, ते शांतीलाल शहा या कमिटीत होते. त्यांनी मतिमंद मुलांसाठी शाळा पण काढलेली होती, शिरोडकर स्पेशल स्कूल फॉर मेंटली रिटार्डेड चिल्ड्रन. एवढं सामाजिक भान डॉक्टर शिरोडकरांना होतं. डॉक्टर शिरोडकर नावाजलेले डॉक्टर होते. त्यांचे रुग्ण म्हणजे सोफिया लॉरेन आणि माजी पंतप्रधान इंदिरा गांधी यांची राजीव गांधी यांच्या वेळेसच्या डिलिव्हरीच्या वेळेस त्यांनी शिरोडकर यांना कन्सल्टंट म्हणून निवडलेलं होतं. शिरोडकर डॉक्टर असल्याशिवाय एक उत्तम चित्रकार होते. त्यांचं हाजी अलीचं पेंटिंग आपण पाहत आहात. ते एक उत्तम वादक होते, ते उत्तम शिक्षक होते, ते नवनवीन शोध घेणारे असे अष्टपैलू व्यक्तिमत्व होतं. त्यांच्या ह्या सर्व कामाचा भारत सरकारने त्याची दखल घेतली आणि त्यांना पद्मभूषण 1960 साली आणि पद्मविभूषण 1976 साली देऊन गौरवलं. डॉक्टर शिरोडकरांनी एका मोनोग्राममध्ये लिहिलेलं आहे की विथ ऑल ड्यू रिस्पेक्ट टू द ओल्ड मास्टर्स, आय डिड नॉट कन्सील मायसेल्फ टू सम ऑफ द ऑपरेटिव्ह प्रोसिजर्स विच फेल फार शॉर्ट ऑफ द आयडियल. आयडियाज केम टू माय माइंड फॉर इम्प्रूव्हिंग द टाईम ऑनर्ड मेथड्स. इतक्या नम्रपणे ते कबुली देतात की आदरणीय गुरुजनांचा सन्मान ठेवून मी विनम्रपणे कबुली देतो की काही शस्त्रक्रिया या आदर्शवत नव्हत्या. मला कल्पना सुचत गेल्या आणि मी पूर्वापार चालत आलेल्या शस्त्रक्रियांमध्ये सुधारणा केल्या. डॉक्टर शिरोडकर यांचं व्यक्तिमत्व तर अष्टपैलू होतं आणि आज डॉक्टर दबडे म्हणाले त्याप्रमाणे ते वरून बघत असतील की त्यांच्याबद्दलची माहिती प्रॉपर आणि व्यवस्थित सांगितली जाते का नाही. त्यांची तुलना लिओनार्डो द विंची यांच्याशी होऊ शकते अष्टपैलू व्यक्तिमत्वाशी असं मला वाटतं. डॉक्टर विठ्ठल नागेश शिरोडकर यांच्या नावातच विठ्ठल, त्यांची कीर्तीही विठ्ठलाप्रमाणे. त्यांना माझं शतशः नमन. आणि आता आपल्या शिरोडकर व्याख्यानमालामध्ये पुष्प गुंफण्यासाठी विठ्ठल रूपाने काल प्रकट झालेले डॉक्टर कुलदीप सिंगजी यांचं मी स्वागत करते. आणि माझं भाषण संपवताना मी असं म्हणते की बोलावा विठ्ठल, पहावा विठ्ठल, ऐकावा विठ्ठल, जीवे भावे. धन्यवाद.
Thank you, madam. Thank you, all the dignitaries. I request all the dignitaries to occupy their seats.
बोलणार आहेत ना आता.
I now request chairperson for today's oration, Dr. Virkar sir, consultant gynecologist at Virkar Nursing Home, and co-chairperson, Dr. Meena Gunjotikar, consultant gynecologist at Gunjotikar Nursing Home, to please occupy their seats. Over to you, chairpersons.
Good morning, everyone, respected seniors, teachers, and my dear colleagues. On this auspicious day of late Dr. V.N. Shirodkar Oration, I am honored to welcome and introduce Dr. Kuldeep Singh, an acclaimed sonologist, as our guest speaker. Dr. Kuldeep Singh has dedicated his past 25 years of his life to fetal imaging and diagnosis. But we wonder how his love for this field developed. Born and raised in Lucknow, having completed his schooling at St. Mary's High School and his 12th from Lucknow Christian College, he topped in physics and got a rank of 17th in CPMT exam. He graduated MBBS from King George Medical College, Lucknow, but he soon realized that he had an amazing fascination towards the field of fetal imaging and sonology. And so he went on to pursue his love for his same, and today stands before us as one of the best orators and master trainers in sonology. He has authorized over 200 articles and chapters and sharing his knowledge in the field of USG, and also delivered over 600 lectures at various universities and conferences all over the world, including Japan, France, Italy, Spain, Dubai, etc. He also has 16 books penned and published, which have been translated and acclaimed in various languages and parts of the world. Truly a pioneer in this field, he has been awarded the Imaging Science Award at AICOG Delhi in 2008, along with many other awards and gold medals for his expertise in this area. With such immense knowledge and experience, he decided to start an institute in the name of Sono School, where he trains and develops thousands of students and enthusiasts. Also, his charitable help and work for the poor patients through his skills of sonography should also not go unnoticed. Such a great man of knowledge, he also has cultivated various other hobbies, including playing badminton, cricket. He never misses a spectacle, any cricket match that is held in Delhi, despite his busy schedule. He also loves traveling and visit many countries. He surprisingly loves shopping, and especially when it is for his wife. Along the subject, his wife also plays a huge role in Sono School, where she takes care of day-to-day activities there. She is married to his schoolmate, who is a computer specialist. His elder daughter, Janavi, graduated from Lady Hardwinge Medical College, Delhi, and is planning to pursue further research in pharmacology. His younger son completed his graduation in management and now plans for MBA further on. I know. Now I call upon Dr. Kuldeep Singh, the great Indian in the field of fetal imaging, to the stage and hand it over to him. Thank you.
हाँ जी कॉल माइक दे दीजिएगा। Morning, everybody. I'm honored. Isko band kar de. I'm honored, I'm humbled. Thank you so much for giving me this, to deliver this oration. I'm short of words on that. Thank you so much in terms of giving an oration for this huge academician, Dr.V.N. Shirodkar. Thank you so much, the whole team of Solapur. Thank you, seniors. Thank you, my guides as such, who just keep on guiding me, letting me know where I'm going wrong. That's the whole idea. And this is going to be just a short presentation, which earlier doctors already told us about Dr. V.N. Shirodkar, but I also wanted to be showing how his life has gone on. Then I'm going to be showing you about what exactly was the history of color Doppler. It's never, this is what's happening. It's always the work done before so many years, that is what really matters. If you're looking at a cervix like this, we would have been scared if it wasn't for the person on whose name we're doing this oration. This is hats off to him. So that's the incompetent cervix, but we know there was a surgery, there was a procedure that was envisaged in his name, and we know we are a lot more comfortable. Dr. Vittal Nagesh Shirodkar from 1899 to 1971, a fantastic academician, doctor, and once I tell you about him, that there were so many things which inspire us that we need to be good doctors. Born in Shiroda, graduated from Grant Medical College, went to UK for the Fellow of Royal College of Surgeons, returned to India, joined the JJ Group of Hospitals in 1935, imitable teacher and innovator. Honorary obstetrician and gynecologist at JJ Group of Hospitals, 1935. Again, if you see over here, we are looking at these things and now we are not at all worried about them. You're looking at the herniation of the amnion. This is the functional cervix, and we know plenty of things can be done with it now. If the images are not that bright on, we can just switch off the light over here so that will really help. Most widely known contribution is the Shirodkar cerclage, and there were plenty of contributions for operations for prolapse repair, tuboplasty, creation of new vagina, and he was honored by the Government of India in 1960 by Padma Bhushan and 71 by the Padma Vibhushan. His book over here, and we always remember diamonds are forever. A huge round of applause for our Dr. V.N. Shirodkar. I'm honored again to give this oration, and the topic today is vascular indices and impedance through the trimesters for prognosis, diagnosis, and management in FGR. We question, you answer and learn. That has been the motto coming on across from my teachers. Just going to brief you in a few slides about what happened in ultrasound. How did it all go about? 1958, Lancet paper of Ian Donald, that's how it started off, and his team from Glasgow is when the history of sonography in obstetrics and gynecology dated. 50 years on, it's impossible now to conceive practicing obs and gynae without one of the many forms. You label it 2D, 3D, 4D, color Doppler, power angio, you're going to be using something. But again, it was before Ian Donald, 1801, Thomas Young worked on phase shifting. Christian Doppler, 1842, on the Doppler effect, that when things are moving, how is the thing going to be changing? 1880, Pierre Curie worked on the piezoelectric effect. Paul Langevin in 1915 built the first hydrophone. Things used to go very cumbersome initially. Now with the advent of computers, things are much more comfortable. In the 1960s, umbilical artery waveform as a blind continuous wave started off from Osaka, Japan. 1977, Fitzgerald and John Drum from Dublin. Stool likeness worked in Carol Marshall's department, in the MAMO described the first duplex linear array system, 1980. What they figured out, that in the fetal aorta, the flow velocities are going to be reduced in IUGR or FGR fetuses. The same place, the MAMO duplex Doppler in the mid-1980s across Europe defined the fetal circulatory response to hypoxia. Absolute velocity measurements were inferior, so we went on to looking for the indices, and the topmost was the pulsatility index for the fetal circulation to hypoxia. Vladimir in Rotterdam told us about the compensatory increase in cerebral circulation, 1986. All these things appear very simple to us now, but plenty of work has been done. Vladimir again correlated circulatory changes of behavioral state in 1994, and then Campbell, David Griffin, and Kypros Nicolaides correlated it with the blood gases in 1990 as well. In Australia, Brian Trudinger and Warwick Giles rediscovered the importance of umbilical artery waveform, absent and reversed. Trudinger et al. In 1986. Campbell, uterine artery Doppler waveform, high resistance, making it more associated with preeclampsia. Then Torvid Cassard in 1991 told us about the pulsatility of the ductus venosus, how is it a marker for cardiac function and indicates fetal asphyxia. As we go through the history, we realize that, okay, it went on step by step, not that we press a button and it starts off. Then umbilical and middle cerebral arteries, fundamental requirement for fetal well-being for the timing of delivery of a compromised fetus. The prediction of preeclampsia and FGR by Nicolaides in 2001, but at that time they were studying on 23 weeks fetus. The problem was prevention by agents such as low-dose aspirin did not seem to be effective. Then plenty of work again done by Professor Kypros Nicolaides on preeclampsia in the first trimester, and we're doing in our NT scans the uterine arteries for all of them for the last 10 to 12 years. Now starting off with the moment you're looking at a Doppler waveform, that's why we've kept it on indices and impedances. We have these various formulas telling us what the resistive index is calculated by, the SD ratio or the pulsatility index. But all these three indices tell us about impedance or resistance to the flow. So if these values are high, the resistance is high, and so the blood flow to this particular organ is going to be less, and we need to study that. Now we start off by looking at what is FGR and how does it comprise. What all are the newer things that we need to be careful on? The growth, development and maturation, all that happens, and it is an in utero process. Things happening from 4 to 20 weeks, 20 to 28 weeks, 28 to 40 weeks, and we're going to be looking at whenever there's a dampener here, whether it's symmetric, mixed symmetric and asymmetric, or asymmetric FGR. Yesterday we were discussing about SG and FGR. Earlier on, a small fetus always used to mean an FGR. Weight below the 10th percentile, we are uncomfortable. But we've seen majority with a weight below the 10th percentile can have normal outcomes, and there are a few of them more than the 10th percentile will have adverse outcomes similar to FGR. So a small fetus is not always FGR. We need to be understanding these two aspects, fetal size and fetal growth velocity. Fetal size is a cross-section, what I'm doing today, if I'm seeing the patient for the first time. The prerequisite required is a gestational age and a reference range, and you're going to be doing the biometry by measuring the cranium, abdominal circumference, femur length, and the weight. What's most important is fetal growth velocity. It's a longitudinal assessment. You need to plot the fetal size on charts. There need to be at least 2 measurements so that I know how is the growth curve coming on. It has to be at least 2 weeks apart, and it should be more than 20 weeks. 3 modern prospective fetal growth standards. We have different fetal growth charts, so they're going to be different type of fetuses, different proportions. So you can't be using for a different society. It has to be local population, and we know the outcomes depend on the fetal morbidity and mortality whenever you're implementing them in clinical practice. The fetal size is important because fetal growth restriction and the SGA as well as macrosomia and large for gestational age are associated with an increased risk of perinatal morbidity and mortality. A range of 10 to the 90th percentile traditionally being considered AGA. It's appropriate for gestational age. SGA or LGA, less than the 10th or more than the 90th respectively are the definitions. It's important to note that pathological fetal growth follows more of a gradient, and there are different percentile cutoffs which will result in different portion of fetuses constitutionally small and not growth restricted, and there could be vice versa for larger fetuses. You need a growth chart which is a reference against what to assess. What was it last time 2 weeks ago? What is it today? Where exactly or which percentile was the fetus in and where is it today? And the FGR charts are based on the weight using obstetric sonogram measurements and birth weight growth charts based on measurement birth weight as well. You need to correlate with them. There are individualized ranges for a subsequent fetal growth measurement on a previous fetal growth measurement. So you know exactly where am I going on the percentile. In terms of gestational age, it means how old are you. Growth and growth velocity means how much have you grown. How to identify? We have growth charts to help us, and I'm going to be citing plenty of examples. The growth references depend on the accurate gestational age assessment. Utmost importance has to be given to that, because if the gestational age is unknown or there's an error in the gestational age, it's going to lead to misclassification of SGA, LGA, and are we correctly telling them as AGA fetuses. How do you take out the gestational age? Dating refers to the age assigned to the fetus, usually done by dating, can be by LMP, by ultrasound, or by the date of embryo transfer when we're doing an ART. But please remember, dating is done only once in pregnancy. It cannot be changed with the next scan. We have those various rules by the LMP. We always can be using our pregnancy wheel or the electronic calculator, but it all depends on whether the cycles are regular or the LMP is accurate, otherwise it is not reliable. Looking at ART pregnancies, you're looking at an embryo transfer, fresh or frozen embryo. If you're looking at a blastocyst or a day 3 embryo transfer, 263 plus 3 days, day 5 you're going to be adding up 5 days plus 261, so that the total number of days adds up to 266, and then you add your 14 days to it. How do you estimate gestational age? The SOGS guidelines say between 4 weeks and 3 days to 5 weeks and 6 days. It is going to be measured by the mean sac diameter of the gestational sac. But do not date it, do not assign an EDT. From 6 to 9 weeks and 6 days is going to be the crown rump length. Between 10 to 13 weeks and 6 days, it's again going to be the crown rump length, but after 12 weeks they say add on the BPD as well. From 14 to 24 weeks, the HC and or the femur length both should be agreeing. After 24 weeks, assess the size, but don't label it, don't label a gestational age after 24 weeks. What's the protocol for a fetal growth restriction? You need to identify a small fetus. Once you've identified, you need to label them whether it's an FGR or an SGA. If it's an FGR, whether it's early or it is late FGR. You need to have the parameters for fetal follow-up and you need to have a stage-based management protocol. How do you identify a small fetus? Establish the gestational age, estimate the fetal weight, and calculate the weight percentile. In the first trimester, the moment you're looking at a crown rump length, and that's within 5 days of the patient's menstrual dating, it will accurately date the pregnancy. Transvaginal scan can visualize a gestational sac as early as 4.5 weeks, or the moment we cross the discriminatory zone, we should be looking at a gestational sac. The first trimester crown rump length, if it is 2 to 6 days smaller than expected, it could be associated with an increased risk of a birth weight below 2.5 kgs, a birth weight below the 5th percentile, or a delivery between 24 to 32, so be very cautious. We're looking at a gestational sac, embryo, that's the amnion, that's the yolk sac. Always and always, whenever you're doing a dating scan, do not do it at 5.5 to 6.5 weeks, do it between 7 to 8 weeks. One, because you'll be able to see the crown rump length much better, the yolk sac would not be superimposed, and even if our hand shakes, we a proper measurement of the crown rump length. When you're looking at measuring the crown rump length, be careful that the magnification of the image should be such that the fetus is occupying 60 to 98% of the screen. Be watchful for that and then go on to take your NT measurements. It has to be carefully looked in for that you clearly define the crown and the rump points. Be careful, it's again a neutral position. Don't put all the help or all the knowledge on just the NT. Even a crown rump length measurement at that stage is quite crucial. In terms of looking at in the second trimester pregnancy dating, prior to 20 weeks gestational is reliable if the fetal biometry is within 10 days. So in the first trimester, if the crown rump length is within 5 days, you assign the LMP properly. In the second trimester, it's within 10 days, you assign the LMP or you have a fresh date. But in this, only if this is the first scan that is being done. If you've already done one in the first trimester, that's the ultimate, and that is where the EDDs or the gestational age is assigned. You're supposed to take the femur length, head circumference, BPD, and the abdominal circumference. Beyond 20 weeks, the BPD could diverge almost 12 to 15 days, and 30 to 32 weeks later, the difference could be as great as 3 weeks. So, no measurements of the gestational age after 24 weeks specifically. Because of this discrepancy, femur length is frequently chosen as a dependable indicator. All the measurements and the sections have to be taken properly. Due diligence, due importance has to be given. The BPD has to be measured in a transverse or an axial plane, and the thalami and the cavum, septum, pellucidum should be seen. The transducer has to be perpendicular to the central axis of the head so that you should see the complete skull portion. From the outer to the inner is the BPD measurement. The cerebral hemispheres usually not to be in that plane. You're looking at the thalamus, you're looking at the cavum, septum, pellucidum. From outer to inner is the BPD measurement. In terms of looking at the abdominal circumference, again an axial or a transverse section has to be taken. Through the upper abdomen should demonstrate the fetal stomach, the umbilical vein, and the portal sinus. The kidneys should not be visible, and you should be placing your calipers across the skin surface. The gallbladder can sometimes be seen. You're looking at the stomach, you're looking at the vertebra, you could be seeing the suprarenals. You're supposed to be looking at this J-shaped pattern over here. That is absolutely fine. No kidneys to be seen over there. The suprarenal, the J-shape, the stomach bubble, and you're supposed to be measuring it from the skin surface so that you get a proper measurement. Do not compress it unnecessarily, you're going to get a wrong reading. Looking at the femoral length, again measure it from the shadow to the shadow over here. That's the correct way of measuring the femoral length. In terms of measuring the estimated fetal weight, I normally follow the charts where the BPD, head circumference, femoral length, and the abdominal circumference. We have by Shepard et al., Hadlock et al., but we need to understand we are dealing with Indian babies, so we have plenty of Indian authors who've given. I have fed those charts in my machine, and they are much more reliable and relatable. Now, of all the fetuses where you're looking at a weight below the 10th percentile, 70% are going to be small for gestational age with no additional risk of perinatal morbidity and mortality. As compared to appropriate for gestational age, these are true SGAs or constitutionally small babies. The remaining 30% are FGRs. Otherwise, the moment it was 10th, we would have worried and said all of them are FGRs. What are percentiles? The fetuses come in all shapes and sizes. So you need to plot the growth charts by using the percentiles. And what are percentiles? Extremely important, because now the picture of the baby should be consisting or measuring the percentiles as well. There has to be a picture there as well. If you're looking at a baby or the fetus on the 50th percentile, that means it's in the middle of the normal weight range. 50% babies are going to be lighter, 50% heavier. If you're looking at on the 5th percentile, means it weighs less than 95% of other babies of that age. If you're looking at a baby on the 90th percentile, means it weighs more than 90% of other babies at that age. So an SGA fetus is a weight below the 10th percentile for gestational age, otherwise healthy, has a relatively low risk for perinatal morbidity and mortality. FGR fetus is typically very small with a weight below the 3rd percentile, or looking at this is irrespective of normal or abnormal Dopplers, or you're looking at a weight below the 10th percentile with Doppler abnormalities in the fetoplacental or the uteroplacental circulation. There's so much developments happening in maternal and fetal circulation. Looking at the fetal heart rate analysis, looking at the biophysical profile, that it has improved the diagnosis of both FGR and SGA. SGA fetuses usually exhibit normal fetal Doppler. FGA, there is an element of placental disease exhibiting maternal and fetal Doppler abnormalities. Serial ultrasound scans to be used to construct longitudinal growth charts. You're looking at several measurements plotted over there. And the moment there's a deviation from the growth velocity, we are going to be assessing it for its relevance on fetal growth rather than fetal size. So whenever you are taking the patient again, use the same ID. There is a trend thing on the machine, and it's going to be plotting it the same one that was there earlier. If you see over here, 5 measurements over here, and they've been plotted. The 50th, the 10th, the 90th percentile. So we know where exactly is this baby going on, starting from the 2nd trimester till the 3rd trimester. Abdominal circumference, femoral length, weight pattern over there. That's the HC-AC ratio. So the HC is going to go down, this value is going to keep on increasing. Again, the same thing, weight below the 10th, SGA, below the 3rd, or below the 10th with the abnormal Doppler, FGR. We're looking at a normal, appropriate for gestational age. Looking at all this is not a patient, this is where I have plotted this. Even if you're looking at going down till the 10th, but it's still within the range, and we are comfortable as long as we're not looking at trouble. Now, the moment there is a problem, it goes below the 10th percentile, but before 32 weeks, we're going to be labeling and thinking of early FGR. That's where the cutoff is. After 32 weeks, we're going to be calling it late FGR. This baby had a potential of being a small baby only. So it started off at the 10th percentile, and till the end it hasn't gone down further, it's on the 10th. So it's a constitutionally small fetus. Now the new bracket that's coming on is deceleration of fetal growth rate as an alternative predictor for childhood outcomes. That was this study over here, which said the fetus, even if it's at initially the 90th percentile, but ending at the 50th percentile, expressed in estimated fetal weight, more growth decelerated compared with the fetus at the 70th and goes to the 30th. So even if it's on the 50th percentile, you have to see from where it's coming below. Might be this baby has a potential of being a 4 kg baby, landing up as a 2.5. We need to be watchful. So now this explored certain more differences in the outcome between SGA, and this was a growth decelerated fetus. It was born AGA, but it was a vulnerable group with increased risk of accelerated growth and altered cardiovascular outcomes in childhood and in future lives. So you need to be watchful. There's plenty of research going on a particular group, since these newborns are now focusing on birth weight, which is not only less than the 10th percentile, but the attention has to be for the ones who are above as well, in which it's going down. Started off as the 90th, gradually coming down. That's when the red signal comes on. So if it's coming down below more than 30th or 40th percentile, just be watchful that you're not looking at trouble. The sonographic diagnosis of SGA, weights calculated by all this, less than the 10th percentile. Not all SGA are growth restricted, not all FGRs have a birth weight below the 10th percentile, the new bracket that I showed you just now, and 10% of AGA fetuses could also be growth restricted. We have a late onset and we have a early onset FGR, depends on the moment of onset, the evolution, the Doppler parameters, because you have a different set of Dopplers where things are going to go bad, and the postnatal outcome. The best cutoff is at 32 weeks in terms of perinatal outcome. The antenatal diagnosis, treatment, and timely delivery could diminish the risk significantly. Universal references would make comparison of fetal growth rates for clinical use and comparison across populations. But again, as I said earlier, local population, local growth reference charts, you need to be following them up. Key messages on 2D, and then I start off with the Doppler. You need to have a detailed maternal history, early and accurate dating. Date only once in pregnancy. The fetal size is assessed by the EFW. The growth velocity is assessed by growth charts. Use the standard charts. Don't use machine values blindly. We need to be seeing through our own crooked eyes as to where exactly are we looking at. In terms of FGR and placental dysfunction, what do we monitor? We're looking at biometry and growth charts. We're looking at compensatory mechanisms. We're looking at features predicting hypoxia and acidemia on Doppler, and looking at the environment by the amniotic fluid index, CTG, and the biophysical profile. This is a chart working on pathophysiology. You're looking at which, I think so it must be quite small, so you mustn't be, but I'll just read that out. There's a first trimester invasion of the spiral arteries, second trimester invasion of the radial arteries. The moment there's because of this, an improper trophoblastic invasion on your Dopplers, you're going to see it as an abnormal uterine artery. If there is increased placental obliteration, FGR, PIH, diabetes, discordant twins, things are going to go bad in the umbilical artery. What happens next? Hypoxia. There's an aortic body chemoreceptor stimulation, and there's a reflex redistribution where there's going to be less blood flow going to the non-vital organs, that's let's say the gut. So there's going to be increased resistance in the aorta. There's going to be more blood flow going towards the brain, which is the most vital organ. So the moment we have this means the resistance of the PI value is going to go down. With increase in hypoxia, the heart is going to start taking its toll, and you're going to find changes in the ductus venosus and the umbilical vein. With further hypoxia, the brain sparing effect is going to give way and there is going to be brain edema. I'm not going into these because I'm going to be explaining them. In terms of interpretation of fetal arterial Doppler, severe fetal redistribution would normally be followed within 2 weeks. When there's a reduced biophysical profile, abnormal venous Doppler and suboptimal CTG. A growth-restricted fetus would usually develop an abnormal umbilical artery waveform before developing fetal arterial redistribution. You need to be very watchful for your CPR, cerebro-placental ratio. That's the MCA PI divided by the umbilical artery PI. Most sensitive for redistribution of blood in fetal hypoxia. And this could go abnormal even before the middle cerebral or the umbilical artery PI tends to go bad. CPR of less than 1 is the earliest sign of redistribution, a sensitive marker, especially in late onset FGR. That's the cutoff. The moment the CPR is going to go bad, you need to. In fact, when I was coming to Pune, there was a doctor who said the CPR is going down. She was 36.5 weeks. Can I wait for 2 more days? Nothing doing. Her baby has to be delivered. And by the time I landed in Pune, the husband sent me a message, baby delivered. Abnormal CPR, higher incidence of fetal distress in labor requiring an emergency cesarean delivery, lower cord pH, and an increased admission rate to the NICU. Why is venous Doppler so important? Especially when you're looking at early onset or less than 30 weeks for severely growth retarded fetuses. It's basically used to prolong the pregnancy by 1 to 2 days so that you have time to give the steroids for lung maturation. The goal of venous Dopplers is to provide additional non-invasive information on the functional capacity of the fetal heart to help determine the optimum timing of delivery. Absent or reversed end diastolic flow in the umbilical artery, you need to be looking at the venous Dopplers. In fact, what I do is I take the uterine, the umbilical, the middle cerebral, and the ductus venosus for all fetuses. You need to be looking at the changes that are happening. There's a growth lag. There's going to be increased blood flow going to the brain, less blood flow in the umbilical artery. Redistribution started, the weight going down, amniotic fluid going down, ductus venosus going bad, absent or reversed the umbilical artery flow, and we're looking at abnormal CTG, abnormal biophysical scoring, and fetal death. Now what happens is, if you're looking at less than 32 weeks, you're going to wait till this point. What the bookmark studies say is that if you're looking at absent end diastolic flow and the baby is 34 weeks, deliver. You're looking at reversal of end diastolic flow, the baby is more than 30 weeks, deliver. Irrespective of what you're looking at, even on the ductus venosus, because our neonatal facilities and ICUs have really gone better. The moment you're looking at late onset, the redistribution of the CPR goes abnormal, deliver. And why we're so skeptical about early and late. This is the sequence of events that happens in early onset FGR. You're looking at chronic or diagnostic markers. Gradually things going bad in weeks. Acute, you're looking at advanced hypoxia, serious injuries, ductus venosus reversal, CTG, but that's going to take 7 to 10 days. What happens in late onset FGRs? This portion takes weeks to happen, but the acute deterioration can take place in hours. So we do not know when that's going to happen. Be very watchful. So the stage-based management, classification and management of FGR. If it's an SGA fetus, you're looking at a weight less than the 10th percentile. All the Doppler values are normal. Looking at a fortnightly Doppler. Looking at growth assessment. Labor induction recommended at 40 weeks. So be watchful on that. This is how you're looking at normal uterine arteries. No notches, plenty of diastolic flow. You're looking at the iliac vessels, plenty of flow over there seen in diastole. Now why is uterine artery so useful and helpful? It identifies about 50% of those that are going to subsequently develop preeclampsia, and that also severe rather than mild. It is going to identify about 30% of those who are going to be going in for FGR, that also is severe. In severe birth weight below the third centile before 35 weeks. In terms of the likelihood ratio, if the uterine artery is normal, does not mean that there can be no problem. Chances are less. If the uterine artery is abnormal, doesn't mean all of them are going to have trouble. The chances increase. So in a normal, this is the likelihood ratio of FGR, preeclampsia, perinatal death. It goes on 5 times if the uterine artery is abnormal, 10 times preeclampsia, 3 times for perinatal death. So you can use uterine arteries for screening, but why can't you use umbilical artery Dopplers for screening? Because 70% of the placental tertiary villi should be affected to show changes in the waveform. And even when 40% of the villi are affected, FGR would be present. So by the time I start seeing changes, things have gone bad, so we can't use this as a screening one. The mid portion of the umbilical cord has to be insonated. And you again looking at the diastolic flow. You can take a manual measurement, you can either take a semi-automatic or an automatic measurement. You can use the PI or the SD ratio depending on whichever charts you're using. Looking at the middle cerebral artery, that's the thalamus, that's the middle cerebral artery. Looking at the anterior communicating anterior cerebral, posterior communicating and posterior, we are interested in looking at the middle cerebral artery. You insonate that, and this is the value that you're going to be looking at. Less amount of diastolic flow, because the moment the diastolic flow increases means the resistance is going down and nature is trying to send in more blood flow to the cranium. Ductus venosus, that's the umbilical vein coming inside, that's the liver portion over here. The moment you're looking at turbulence over here, this is where you are going to be looking at the ductus venosus. You can see it on a longitudinal section, you can see it on a transverse section, whichever way you are comfortable. Narrow vessel going inside the inferior vena cava. You're looking at a particular M sort of a pattern. This is not reversal. Click the invert button and it will go up. Ventricular systole, ventricular diastole, atrial systole, and you're interested in, this should not be going down. That's the first sign of trouble. Absent, major sign, and when we're looking at reversal is when we know we're looking at deep trouble. M sort of a pattern. Now there's another vessel that's come up, and that's the aortic isthmus. Putting in a word in a few slides so that we all should be starting to seeing it. Ductus venosus is a marker for the right side of the heart. Aortic isthmus is a marker for the left side of the heart, and this is what starts going bad initially. You can have it in the longitudinal arch view, or you can have it in the 3-vessel trachea view. You're supposed to be making sure that you're using your color Doppler judiciously. This is a watershed. There are basically 3 watersheds: left portal vein, foramen ovale, and the aortic isthmus, where the mixing takes place. I'm going to be showing you the videos. There you can see that. We're looking at the anterior most. That is where you're looking at the ductus arteriosus. The aortic arch is the one that's going to be going more superiorly, and before it joins the ductus arteriosus is where you're going to be looking at the aortic isthmus. Once it gives off the subclavian artery, this is the place for the aortic isthmus. You need to insonate that. And why is this helpful? Because the moment you're looking at there's not enough blood flowing to the brain, nature is going to be stealing it from here. So the flow that's supposed to go this side is going to go backwards so that it can supply to the baby's brain. That's the most vital organ. That's a transverse section that I'm looking at. The moment I'm seeing a V over here, that's the V. This is P, A, and S, that's the trachea over there. So the moment you're looking at the pulmonary artery, the last portion is the ductus arteriosus, last portion over here is the aortic isthmus, as we demonstrated yesterday. Seeing on color, the moment the subclavian vessel is given off, before it joins the ductus, this is the aortic isthmus. The best way to start off Dopplers, for the ones who are not doing it, start off at 28 or 32 weeks and gradually come down. You'll be able to do a fantastic job. Transverse section. The right pulmonary artery, there you're looking at the V. This is the ductus arteriosus, last portion is the aortic isthmus. That's the sort of flow that you're going to be looking at. The moment you're not seeing flow in this direction, going in the opposite, is when you know you're looking at trouble. That's where we've insonated the aortic isthmus. Now coming on to FGR, early onset FGR, less than 32 weeks. Easy to identify, but difficult to manage because of prematurity. They suffer chronic hypoxia. They're fighters, so they're better tolerance to hypoxia. 20 to 30% of FGRs are early onset, and you can see early PE in almost 50%. Late onset FGRs, after 32 weeks, difficult to identify because you feel you're not going to be doing an ultrasound every week or every 10 days. So the moment you're looking at some susceptibility of a problem, definitely call them back. Difficult to identify, they have a poor tolerance to hypoxia. They're not used to adverse conditions. Almost 50% of unexplained near-term stillbirths are because of this. 70 to 80% of FGRs and associated with the altered PE is low. The same thing being put up in terms of the graph over there. Early FGR, you're looking at a weight below the 3rd percentile, or you're looking at less than the 10th percentile combined with uterine artery or umbilical artery going bad. Late onset, weight less than the 3rd percentile or less than the 10th percentile, or the CPR going bad, you know you're looking at trouble. The first stage we're looking for FGR, the Gratikos classification, you're looking at mild placental insufficiency. The uterine artery, umbilical artery, middle cerebral artery, or the CPR could be abnormal. You need to be doing a weekly monitoring. Labor induction beyond 37 weeks is acceptable, but you need to be looking at the risk of intrapartum fetal distress. You're looking at notching. You're looking at changes in the uterine artery. Changes in the uterine artery. You're looking at the umbilical artery, which was fine, but it's gradually the diastolic flow is reducing. The PI value is going high. You're looking at an SD ratio of 6.87, looking at a PI of much more than 1.5, that's 2.11. You're looking at a gradual increase in the diastolic flow in the middle cerebral artery. You're looking at brain sparing, where the PI value of the middle cerebral artery is less than 1. Stage 2 FGR, where you're looking at severe placental insufficiency, absent end diastolic flow. You're going to be monitoring them twice a week. Delivery to be recommended after 34 weeks. Absent end diastolic flow. Positive predictive value for antenatal asphyxia as high as 92%. And it precedes the FHR anomalies. Before the NST or the biophysical starts going bad, you're going to find changes in the umbilical. There, look at that. Absent end diastolic flow. You're looking at mode flow in the middle cerebral artery. Stage 3, where you're looking at advanced fetal deterioration, reversal of end diastolic flow. Ductus venosus PI, again the diastolic flow is reducing. You need to be monitoring them every 24 to 48 hours. Delivery to be recommended by cesarean after 30 weeks. Reversal of flow in the umbilical artery. Reversal of flow. Ductus venosus flow reducing. The diastolic flow is reducing. The values are going high because we need to have an SA ratio, systole aortic ratio. The final stage of FGR, high suspicion of fetal acidosis, high risk of fetal death. There's going to be FHR deceleration or a pulsatile ductus venosus. You got barely 12 to 24 hours, otherwise immediately deliver the baby. Delivery after 26 weeks by a cesarean section, but at a tertiary care center, and you need to be making sure of whatever best we can get for lung maturation. Deceleration. We know we're going to be losing the baby if we don't act fast. How much of a limb baby we're going to be getting, we're not sure, but we have to give our best. Ductus venosus, reversal happening. So preterm growth restricted fetus with elevated umbilical artery resistance has an overall perinatal mortality rate of almost 6%. It doubles if the end diastolic velocity is absent. It rises to almost 6 times from here or more if the venous Doppler indices also become abnormal. So a reverse flow in the umbilical artery along with the pathological waveform in the venous system, best predictors of severe fetal distress. Termination of pregnancy must be considered as soon as possible. How often monitoring? We've already discussed that, but again the frequency is dictated by the severity of growth restriction, the gestational age. Biometry to be done every 2 to 3 weeks, there's no point repeating it every day. Doppler again depends, if it's mild, every 2 to 3 weeks, weekly or bi-weekly if you're looking at trouble, AFI every week or bi-weekly. When to deliver? The gestational age at decompensation is the primary determinant. I'm looking at abnormal changes. If I'm seeing 36, 37, why do I need to wait? Neonatal care available dictates the gestational age. If at my center I can take care of a 1.8 kg baby, I'm comfortable. But if I'm looking at a 1.2, I'd either like to wait or send them off somewhere else. Less than 32 weeks, every day gained is useful. Every week gained, the outcome improves by 40%. Venous Dopplers help in delaying the delivery. More than 30 to 34 weeks, steroids and delivery once the umbilical artery shows absent or reversed. What's the aim of delivery? Is it just a live fetus? No. Intact survivability. We need to be giving not a limb baby but a rollicking baby whom everybody is happy taking back home rather than spending time and making that there are a few changes happening either soon after delivery or after 1 year or after 2 years. So the risk of intrauterine compromise has to be weighed against the potential risk for iatrogenic premature delivery. When all should we screen for FGR? Mid-trimester anomaly scan, start being watchful. You already have a dating scan. You already have an NT scan. If you find things are going down by a week, just put it in your notes. We need to be doing additional third trimester scans for them. We need to be looking at what all risk factors are there, and we need to be adding on the scans. It is always better to spend the money on scans rather than later spending the money on the ICU units. Whenever there's an abnormal biometry, even quite early, it should trigger a referral for detailed assessment. Make sure the dating is accurate. Are there any factors, maternal or fetal, that we can look in for trouble? So make sure wherever required, get a karyotype done. Timely referral to an appropriate unit for individualized management. Depends on many factors including maternal factors, gestational age, result of ultrasound and the various tests. Abnormal biometry, maternal symptoms of hypertension and or absent or reverse end diastolic velocity should prompt urgent referral to a subspecialist in a high-risk pregnancy. The primary goal of antenatal evaluation is to identify fetus at risk for intrauterine injury and death so that timely intervention, timely delivery can prevent progression to stillbirth. That's what the aim of every one of us is. Management of FGR and the decision to deliver is an optimum balance between minimizing fetal injury or death versus risk of iatrogenic prematurity. Friends, we need to be doing it right from our NT scans. We need to be doing our dating scans. Carefully watch your Dopplers, take your measurements correctly so that we do a fantastic job of giving good, healthy babies to proud parents. Thank you. Thank you so much.
Sir, for your wonderful lecture. I hand over to Ketki.
I now request Shirodkar sir to present the silver plaque and citation to our esteemed orator, Dr. Kuldeep Singh sir. Lights.
So,
The Solapur Obstetrics and Gynecological Society is honored to present late Dr. V.N. Shirodkar Oration Award to Dr. Kuldeep Singh for his outstanding contribution in the field of ultrasonography in OBGY on Sunday, 7th April 2024. President Dr. Virkar, Honorary Secretary Dr. Gunjotikar. We, the President, the office bearers, the members of Executive Committee of Solapur Obstetrics and Gynecological Society are pleased to present the late Dr. V.N. Shirodkar Award 2024 to Dr. Kuldeep Singh on 7th April 2024. A master trainer in the field of imaging, known for his skills in ultrasound, in obstetrics and gynecology, and infertility. You are practicing ultrasound at New Delhi for past 25 years. Your academic qualifications and recognition for your work for various parts of the world truly exemplify your proficiency and love towards the ultrasound. You are very passionate about your work and you have successfully trained thousands of students through various training programs organized by Sono School. You have authorized 16 books, and some of these have been translated into Spanish, Chinese, Portuguese languages. You have been awarded Imaging Science Award at AICOG Delhi, and you have also received 3 gold medals for your work done in the field of ultrasonography. Truly to your name, Kuldeep, the enlightened one, you have shared your knowledge and ultrasonography and enlightened to all of us. It is a proud privilege to present to you today the prestigious late Dr. V.N. Shirodkar Award 2024 for your excellent and educative lecture on vascular indices and impedance through the trimesters for prognosis, diagnosis, and management in FGR.
Thank you. Thank you all. All are invited for lunch.